So imagine you go in for a highly successful, minimally invasive surgery to fix a really frustrating problem, urinary leakage.
Right.
You wake up, you recover, and the leak is completely gone. But there is a new nightmare. Suddenly you can't go to the bathroom at all.
Yeah, it's the absolute definition of a clinical dilemma.
Wow.
You've traded one quality of life issue for another, potentially more dangerous one. A patient goes into the operating room hoping to regain their freedom, only to wake up facing an entirely unexpected, well, mechanical roadblock.
Exactly. And today, we are taking your stack of medical sources to explore that exact roadblock. We're looking to answer a highly specific, crucial question.
It's a big one.
Right. If a surgical implant, specifically a mid-urethral sling, causes severe obstructive urinary symptoms, can it simply be adjusted or loosened?
Which is such a vital question for anyone going through this.
It really is. To give you some context on why this matters to so many people, we are talking about stress urinary incontinence, or SUI. This is a condition affecting up to 1 in 3 women worldwide. It's that leakage of urine that happens with everyday physical activities. You cough, you sneeze, you laugh, you go for a run, and there's an involuntary leak.
Yeah, the mechanics behind that leakage are actually quite straightforward when you look at the anatomy.
Right.
The natural ligaments and pelvic floor muscles supporting the urethra, which is, the tube that carries urine out of the bladder, they've been weakened.
Because of things like childbirth.
Right. Exactly. Childbirth, hormonal changes, or simply just the natural aging process.
Makes sense.
So, when the pressure inside your abdomen suddenly increases during a laugh or a cough, the urethra doesn't have a firm backstop to compress against.
So it just kind of gives way.
Right. It gets pushed down, it doesn't stay firmly closed, and urine escapes.
And the most common surgical fix in the world for this loss support is the mid-urethral sling.
It is.
I mean, over 3 million of these procedures have been performed globally. It's a massive success story in the medical world, boasting a continent success rate of over 90%.
The numbers are incredible.
They really are. The implant itself is essentially a 1 centimeter wide strip of synthetic polypropylene mesh.
Right, a tiny strip.
Yeah. The surgeon places it beneath the urethra to act like a tiny hammock, providing that missing backstop. Okay, let's unpack this.
Yeah.
How exactly is this tiny piece of mesh put into the body, and why does fixing the leak sometimes cause a complete obstruction?
Well, to understand the complication, you have to look closely at the brilliant yet highly delicate design of the implant itself.
Okay.
The sling is technically placed tension-free beneath the midsection of the urethra.
Tension-free, so not tight.
Exactly. The surgical goal is never to pull the urethra tight like a tourniquet. Instead, it's meant to loosely mimic those natural supportive ligaments. The mesh material is woven, meaning it's full of tiny pores or holes. And over the course of about 3 to 4 weeks following the surgery, the patient's own connective tissue actually grows through those microscopic holes in the mesh weave.
Oh, wow.
Yeah, the body sends fibroblasts and collagen to the area, naturally incorporating this synthetic material into the patient's own fascia.
So it's less like tying a knot and more like, I don't know, planting a trellis in a garden.
That's a great way to think about it.
Right, like you place the wooden lattice into the dirt loosely, but once the vines, or in this case the body's native tissues, grow through it and wrap around the rungs, the structure becomes permanently anchored.
It becomes completely locked into the landscape.
Wow.
And once those vines lock in, we hit a major complication for a subset of patients.
The voiding dysfunction.
Right. In up to 20% of cases, patients develop post-operative voiding dysfunction, also known as bladder outlet obstruction.
20% is a lot.
It is. And the presentation varies wildly. Some patients might just notice a much slower urine stream.
Right.
Others might have an elevated post-void residual volume, meaning they try to empty their bladder. But ultrasound shows they still have more than 200 milliliters of urine trapped inside.
Oh, that's terrible.
And in the most severe cases, they experience complete urinary retention. They simply cannot void at all.
I can't even imagine.
That's awful. It can even trigger de novo overactive bladder symptoms. Because the bladder is struggling against a blockage, it becomes highly irritable.
Like it's constantly trying to push past a wall.
Exactly. Causing a sudden, severe, and frequent urge to go, even when the patient physically can't.
Which has to be incredibly distressing for the patient.
Oh, absolutely.
I mean, the sources note that between 1 and 10% of patients might still be entirely catheter-dependent 28 days after the surgery.
Yeah, just living their day-to-day lives with a tube.
Just trying to manage their daily lives with a tube draining their bladder? But wait, If this hammock is placed tension-free to begin with, how on earth is it causing a physical obstruction?
Well, this raises an important question about the dynamic, constantly shifting nature of the human body.
Okay.
Obstruction is rarely just a matter of the surgeon pulling the tape too tight by accident. Remember, the entire pelvic region is actively healing.
Right. There's trauma from the surgery.
Exactly.
Yeah.
Individual anatomical differences, significant post-operative tissue swelling, or even microscopic misjudgments in the angle of the mesh placement can lead to dynamic compression of the urethra.
Dynamic compression.
Yeah. One of our sources analyzed ultrasound imaging of these patients. And the imaging showed that the obstruction often happens dynamically when the patient strains to pee.
Oh, I see.
The tension-free hammock suddenly acts as a rigid, tight wall when the abdominal muscles bear down.
Because this obstruction is often driven by that temporary swelling or dynamic changes, surgeons can't just immediately rush back into the operating room to rip the mesh out, right?
No, not at all.
The guidelines in your sources strictly dictate that the first line of defense has to be conservative. The immediate approach is to watch and wait.
Right. The initial management protocol is entirely non-surgical, focusing on temporary relief while the body heals.
So medication.
Yeah, doctors will often prescribe alpha-adrenergic blockers. These are medications designed to medically relax the smooth muscle fibers located around the bladder neck and the female urethra.
Makes sense.
By relaxing those specific muscles, you decrease the resistance the bladder has to push against.
And what if that doesn't work?
If the bladder is retaining a dangerously high volume of urine, the patient is taught clean intermittent catheterization, or CIC.
The patient is manually inserting a small, clean tube through the urethra several times a day to drain the trapped urine.
Yes.
And the clinical reasoning for putting a patient through this routine is a strong medical trend towards spontaneous resolution.
Exactly. The medical team is essentially buying time, waiting to see if the tissue inflammation and hematomas...
The localized bleeding.
Right, the localized bleeding from the initial surgery, they just want to see if that needs time to subside.
They want to see if the body will correct the obstruction on its own once the trauma of the surgery fades.
Especially if the post-void residual volume is hovering around that 200 milliliter mark rather than complete retention. We're looking at a critical period of watchful observation.
Giving the pelvic floor a chance to settle into its new anatomy?
Exactly.
But I have to push back here on behalf of the listener. Telling a patient who cannot empty their bladder to just watch and wait sounds terrifying.
It does.
Doesn't leaving a bladder physically obstructed risk causing long-term irreversible damage?
That is a very real concern.
I mean, I'm thinking about the detrusor muscle, the main muscle lining the bladder wall. If you force a muscle to constantly push against a blocked pipe, doesn't it eventually just tire out, thicken, and fail permanently?
You are hitting on one of the most fiercely debated controversies in urogynecology.
Really?
Yeah. The concern you just raised is entirely valid. There is a very real, documented risk of irreversible detrusor damage if a severe obstruction is left unmanaged for too long. Think of the bladder like a specialized balloon. If you constantly try to inflate it against immense resistance, the rubber doesn't get stronger in a functional way.
It gets weirdly stretched out.
The muscle fibers hypertrophy, they thicken abnormally, they become fibrotic, and they lose their natural elasticity and compliance. Eventually, the pump simply fails.
So why the hesitation to just go in and fix it immediately?
Because surgeons must balance that risk of long-term bladder damage against the severe trauma of subjecting the pelvic floor to a second surgery before it is even healed from the first.
Oh, because everything is still raw.
Exactly. Going back into the vaginal tissue while everything is acutely inflamed, swollen, and actively bleeding carries its own set of serious risks.
Like infection.
Infection, severe scarring, or accidentally damaging the urethra itself. It is a razor-thin tightrope walk between acting too early and acting too late.
When that waiting period fails, however, when the swelling has clearly gone down, the patient has been catheterizing, but they still cannot void, we arrive at the core mission of this deep dive. Can the sling actually be loosened? The sources say yes, but the catch is the clock is relentlessly ticking on when that is possible.
It really is. The intervention is called sling mobilization, or transurethral sling loosening.
Okay.
But it comes with a massive caveat regarding timing. Expert consensus states that the specific loosening technique is mostly successful only in the acute setting.
How acute?
We are talking about a golden window of within 2 weeks of the initial insertion.
Because of the trellis effect.
Yes.
You have to
Urethral.
intervene before those vines of connective tissue grow through the pores of the mesh and lock it down.
The biology dictates the timeline. Within that 2-week window, the mesh is still relatively free-floating in the tissue tunnel the surgeon created.
Before it's permanent.
Right. The body's fibroblasts haven't had enough time to bridge the gaps in the polypropylene weave.
If they decide to loosen it during that golden window, what does that procedure actually look like for the patient? Are they going back under general anesthesia for a major pelvic surgery?
Fortunately, early mobilization is usually performed as an outpatient procedure under local anesthesia.
Oh, that's a relief.
Yeah. The surgeon reopens the original small incision in the vaginal wall to access the mid-urethra. Once they locate the sling, they use a right-angled clamp or a smooth, curved medical instrument called a urethral sound.
Okay.
They hook the instrument onto the sling and apply firm, direct, downward traction.
They physically tug it downward.
Yes.
The clinical goal, according to the texts, is to pull it down about 1 to 2 centimeters to create roughly 5 millimeters of free space between the synthetic sling and the urethra.
Right, just a tiny bit of breathing room.
The literature actually warns surgeons to be very careful to pull the core of the tape itself. If they just grab the edges and pull, they might just stretch the mesh fibers out of shape without actually mobilizing the entire implant.
Exactly.
Here's where it gets really interesting to me. The mechanics of this fix are so incredibly simple.
They are.
But if the surgeon just hooks the sling and pulls it down a centimeter or two, what stops it from simply sliding right back up into the obstructing position?
It's a great question.
There is no not being untied or retied to hold it at that new lower level.
It seems completely counterintuitive to just pull on it and expect it to stay.
Right.
The reason it maintains its new lowered position relies on a mechanical principle called tissue drag.
Tissue drag.
Yeah. The polypropylene mesh is not smooth, it's highly textured. Even though the tissue hasn't fully grown through the holes yet, the surrounding vaginal epithelium and fascia provide immense friction.
Oh, I see.
That natural resistance against the textured surface of the tape holds it firmly in place once it has been mechanically displaced.
So the friction acts like a temporary glue until the permanent tissue ingrowth happens a few weeks later.
Precisely how it functions.
Wow.
The beauty of this early mobilization is that it has minimal morbidity, meaning the risk of surgical complications is very low, and it often instantly resolves the voiding dysfunction.
That's amazing.
The mechanical kink in the hose is removed, and the patient can immediately empty their bladder again while still maintaining the continence the sling was meant to provide.
Which has to feel like a miracle for someone who has been relying on catheters for 2 weeks.
Truly.
But missing that 2-week golden window changes the entire landscape.
It really does.
Let's say the postoperative swelling masked the core issue, or the patient tried alpha blockers for a month hoping for spontaneous resolution, and now we are at week 5.
Right.
The connective tissue has completely grown through the mesh. The trellis is covered in thick vines. You can no longer just pull it down.
This is where the clinical options escalate, and the conversations with the patient become incredibly heavy.
I can imagine.
Once full tissue ingrowth occurs, true loosening by simply pulling the tape is biologically impossible. The implant is essentially cemented into the pelvic floor.
So you're stuck.
Therefore, the surgical interventions must shift from adjusting the sling to structurally destroying a portion of it.
The sources list several aggressive options here. There is a midline sling incision, which means literally cutting the mesh tape in half directly under the urethra.
Yes.
There is partial or complete excision, where the surgeon cuts out and removes chunks of the embedded mesh.
Right.
And there is urethrolysis, a complex procedure which involves surgically dissecting and freeing the urethra from the surrounding dense scar tissue that is formed around the implant.
Of those options, a simple midline incision is the most commonly recommended approach for early retention that has missed the 2-week window, usually defined as being less than 8 weeks post-op.
Because it's the fastest.
It is the quickest way to relieve the mechanical pressure.
But there is a massive, agonizing catch to cutting that sling.
A huge one.
While severing the tape is highly effective at curing the voiding dysfunction, meaning the patient regains the ability to empty their bladder naturally, it carries a staggering risk of the original stress urinary incontinence returning.
It's a very difficult reality.
The studies show a recurrence rate of leakage anywhere from 9% to 61%.
What's fascinating here is the localized physics of why that failure happens.
Okay, tell me.
When the surgeon incises the sling, they are creating a physical gap in the mesh. The specific area of the urethra sitting directly above that newly cut gap instantly becomes a focal weak point.
I picture it like a suspension bridge.
Yeah, good analogy.
The sling is the central support cable holding up the roadway, which is the urethra. If you realize the cable's pulled too tight and you just take a bolt cutter and snap the central support to relieve the tension, the bridge might rest easily for a moment.
Right.
But the second a heavy load drives over it, or in the bladder's case, the second the patient coughs or sneezes, that exact spot on the bridge buckles. It collapses because the structural floor beneath it is completely gone.
The continuous hammock of support is destroyed, so under abdominal pressure, the urethra hypermobilizes into that gap, and the urine leaks out.
Are patients really told they might have to trade their ability to pee naturally for going right back to leaking?
Sadly, yes. It is a grueling, emotional trade-off to present to a patient.
That sounds devastating.
But when we synthesize the long-term urological data, it becomes very clear why this choice is made. Early relief of a severe obstruction results in a much lower incidence of permanent, lifelong voiding dysfunction.
Because you have to protect the bladder.
Exactly. The health of the detrusor muscle is prioritized.
So, sacrificing the sling and risking the return of the incontinence is medically viewed as the necessary lesser evil to preserve the fundamental function of the bladder itself.
A patient can always try a different incontinence treatment later down the road, such as a non-mesh autologous fascial sling using their own tissue, or bulking agents.
Right, there are other options for leaks.
But you cannot easily replace or repair a permanently damaged fibrotic bladder muscle.
That is a heavy reality. But because that trade-off is so devastating, researchers are desperately looking for an alternative.
They absolutely are.
They have been searching for a middle ground for these late-stage patients who are past the 2-week mark. And one of our sources highlights a novel, minimally invasive outpatient procedure that attempts to bridge this exact gap.
The procedure is known as sling revision with transvaginal tape elongation.
Elongation, meaning they don't cut the central cable of our suspension bridge.
Exactly, no bolt cutters.
Instead of severing the tape and creating that weak gap, this procedure manages to preserve the structural integrity of the sling. It keeps it in its mid-urethral position, maintains its tension-free nature, but essentially stretches the existing material out.
Yes.
But how do they stretch a piece of plastic mesh that is already embedded in human tissue?
It requires an intimate understanding of the mesh's biomechanics. Because the polypropylene is woven, the structure has a slight inherent elasticity to it.
Oh, like a net.
Right. The surgeons go in, carefully dissect the scar tissue away from the edges of the mesh, and use specialized dynamic suturing techniques. They meticulously manipulate the weave to effectively lengthen the existing tape by a few millimeters without breaking its structural continuity.
That's incredibly precise.
It is. They then secure it with sutures, so it heals in that slightly elongated position.
And the outcomes in the provided study were incredibly promising. They looked at a cohort of 12 patients suffering from late-stage voiding dysfunction.
A small group, but very telling.
Right. Following the tape elongation, every single one of them experienced immediate improvement in their lower urinary tract symptoms.
The obstruction was relieved.
Exactly. Now, the big question, did the incontinence come back? In 4 out of the 12 cases, yes, the SUI did recur.
Right.
But, and this is a critical distinction, in 3 of those 4 cases, the recurrent leakage was classified as very mild.
Which is huge.
It was still a massive, life-altering improvement compared to how badly they leaked before their very first surgery.
The researchers also closely tracked the timeline of that recurrence. In the patients who had the elongation procedure, if the leakage did return, it took a much longer time to present compared to patients who simply had their slings cut in half.
That makes a lot of sense mechanically.
Right. The structural support held up much longer. It wasn't an immediate catastrophic failure of the system.
So what does this all mean? If meticulously elongating the tape is clearly so much better for preserving continence than just taking surgical scissors to the mesh, why isn't this the absolute standard of care for everyone who misses that 2-week loosening window?
It comes down to the reality that surgical medicine is highly iterative and reliant on vast amounts of data.
We just don't have enough data yet.
A technique like tape elongation shows incredible theoretical and practical promise for maintaining that delicate balance, keeping the patient dry while allowing them to void normally. However, the study we are analyzing had a very small sample size of just 12 patients. The broader medical community requires long-term, large-scale, multi-centered data before universally adopting a new surgical protocol into the standardized guidelines.
You need to be sure it works for everyone.
Furthermore, this procedure requires a highly specialized, nuanced skill set.
The surgeon's familiarity with complex mesh revisions plays a huge role.
It is technically much harder and much more tedious to delicately dissect and elongate an embedded, scarred-in mesh tape than it is to simply perform a midline incision to cut it in half.
Just literally snipping it.
Right. Not every surgeon performing the initial implant has the specialized training to perform the revision.
To bring all of this together and answer our central mission for this deep dive, yes, a mid-urethral sling can absolutely be adjusted or loosened if it causes severe obstruction.
Yes, it can.
But the how depends entirely, completely on the when. If you catch the obstruction within the first 2 weeks, it is a relatively simple downward tug in an outpatient setting to create a tiny 5 mm buffer of free space, utilizing tissue drag to hold it in place.
Golden window.
But if you wait past a month, the body has claimed that mesh as its own native tissue. You are then looking at either destroying the tape by cutting it or finding a highly specialized surgeon who can attempt to elongate it.
Both of which carry a very real risk that your original leakage problem will return to some degree.
Exactly.
If we connect this to the bigger picture, it highlights a fascinating limitation in our current implant technology.
Oh, how so?
Right now, both patients and surgeons are relying on the body's natural healing timeline, constantly racing against the biological clock of tissue ingrowth.
That 2-week window.
Right. But what if we didn't have to race at all? Given that agonizingly tight 2-week window before the mesh permanently locks into place, could the future of urogynecology move entirely toward universally adjustable implants?
Oh, wow. I am intrigued. Adjustable how?
Our sources briefly note the existence of a system called Remex, which is designed as a mechanically adjustable sling.
Mechanically adjustable.
Yeah. Imagine a medical landscape where a patient develops urinary retention a month or even a year after their surgery.
Okay.
Instead of facing a second invasive surgery, scalpels, incisions, or having to trade their ability to pee for the return of their leakage, they simply walk into an outpatient clinic.
Right.
The doctor accesses a tiny implanted mechanism and turns a small dial to instantly loosen the tension of the sling by a few millimeters from the outside.
Wait, really? By turning a dial, you are completely bypassing the tissue ingrowth problem entirely.
Exactly.
Making the tension mechanically adjustable after the surgery is finished would completely eliminate the agonizing lesser of two evils choice we've been talking about today.
It really would change everything.
You wouldn't have to sacrifice the continence just to save the bladder muscle. That is a brilliant thought to leave off on, imagining a future where the body's healing process doesn't permanently lock us out of a simple fix.
It's very hopeful.
Thank you so much for joining us on this deep dive into the complex mechanics, the anatomical paradoxes, and the ticking biological clocks of pelvic floor surgery. We encourage you to keep questioning the standard procedures, keep researching the mechanisms behind your treatments, and always seek out multiple perspectives on your own medical journeys. Until next time.